Thanks for the honor being invited to your Congress. I'll go through my slides quite quickly because I don't have a lot of time, so I need to finish within 10 minutes. You all know that atrial fibrillation begets heart failure, and the opposite is also true. A lot of patients with heart failure, they do have atrial fibrillation. It's probably about 20% of patients with heart failure have atrial fibrillation and vice versa. So we have a new guideline, ESC guideline for atrial fibrillation 2020. As you see here, if we have HFpEF or HFrEF, nothing is mentioned of HFrEF, but we usually treat it as HFrEF. We can use mainly amiodarone. In my country, dronedarone is not available, and sotalol can be used only in selected patients, usually in the ones that have ischemic heart disease that is resolved. So in most of the patients with heart failure, we have only one drug that we can use, and you see here 1A indication for amiodarone. Dronedarone has one indication as well, but in patients with mildly impaired and stable LV function, and the other drugs usually cannot be used in patients with heart failure. So depending on symptoms, and if the symptoms are AF related, and if they can be controlled by drugs, and if the patient has different preferences, we have favoring factors prevailing for rhythm control. And we have two types of rhythm control. One is achieved by antiarrhythmic drugs, and the other one by pulmonary vein isolation. We usually use them both together. We don't use them separately. And you can see here the factors that favor rhythm control. If you look at the guideline, there is one main recommendation for rhythm control, and it's just for symptom and quality of life improvement in symptomatic patients with atrial fibrillation. And in all patients, we need to consider the patient choice, and we need to consider if the patient fails the drug therapy and if the patient is symptomatic, and of course, what's the patient preference. Now, if we go back to the trials of heart failure and atrial fibrillation, there is a small AATAC trial. There is a problem with this trial, as with most of the similar trials, that it's open label. It's very small. We have about 100 patients randomized to catheter ablation and amiodarone. And if you look here, that's not the typical patient with AFib that you have. So average age was 62 years. It was mainly men. The BMI was not extremely high. There was not a lot of hypertension. At least in my experience, my patients have much more hypertension than that. Not a lot of diabetes, quite unusually high amount of coronary artery disease. So the trial was positive if you look at atrial arrhythmia-free survival at 24, 27 months. And it was positive for hospitalizations as well. And the LV ejection fraction improved more. We have another trial, which is CASTLE-AF, and you see very, very impressive primary outcome reduction. So this was extremely impressive when we saw it. Again, it's heart failure patients with low ejection fraction. All-cause mortality was reduced as well. But this trial has a lot of problems. Again, the age is 64 years, so not the usual patient that you see. Mainly male. The BMI is not so high. It's mainly patients with persistent and paroxysmal, very few with long-standing persistent AFib, and LA diameter was below 50. Most of the patient had CRTD or ICD. Again, the trial was open labeled, and it they used modified intention to treat, and they excluded patients who died or withdrew during the running periods. And this is a slide of Milton Parker, and the problem is that because the enrollment was very sluggish, there were significantly more patients in the control group with ischemic heart disease and diabetes, and more with digitalis therapy. So the control group, if you look at these variables, was at much higher risk at the start of the trial. Now, if you look at the patients that were lost for follow-up or were missing, or the data was excluded, again, we have much more patients in the ablation group that was lost. And because the trial was very small, if, for example, these patients had died, this would affect the results. And when you lose patients, you quite frequently lose them for follow-up because of events. And if we consider that, then the p-value will no longer be statistically significant. They used the definition of symptomatic patients, but it's very difficult to say if the symptoms are due to heart failure or not due to heart failure, due to the AFib per se. And what was very weird is that they screened 10 times of patients compared to the randomized patients. So they randomized only 1 of 10 patients screened, and I don't think they have ever published the exact criteria they were randomizing these patients. So CASTLE-IF is a very impressive trial, but a very problematic trial to be, it's not applicable for the general population, and there is a recent analysis of a large database in the United States that only a small number of patients met the trial inclusion criteria, and the ones that have met the trial inclusion criteria had significant benefit from the treatment. So if you are the patient from CASTLE-IF, whatever that means, then you'll benefit from this treatment, but it's difficult to find this type of patient. Do not forget that there is one negative trial as well, AMICA, which similar to the previous ones, there were patients with low ventricular ejection fraction that were randomized to PVI and to best medical therapy, and there was no difference in the improvement of the left ventricle at follow-up. Now, Cabana was a trial that all the EPs were hoping that it will show a mortality benefit. This didn't happen, and they changed to show more benefit. The authors, they changed to post-hoc on treatment analysis. That's problematic because, for example, if a patient was on drugs and patient was fine for many years and then received ablation towards the end of the trial, then the entire period of benefit of drug therapy was ignored in this case. There are other problems with Cabana as well. The primary outcome was modified. So initially it was overall mortality, and then they moved to a composite of death, disabling stroke, serious bleeding, cardiac arrest, and this was done mid-trial. There was high crossover rate, 27.5, and when you see such high crossover rates, this is always problematic. It doesn't matter what statistics do you have, but that's a problem because the benefits of treatment are diluted. There was a pre-specified subgroup analysis of heart failure patients, and you can see that the rhythm control is much better in this heart failure subgroup within the Cabana trial. In this heart failure subgroup, 60% of patients were with persistent AFib, and the primary endpoint and the mortality were reduced in this subgroup. But this is just hypothesis generating, and we need large RCTs to confirm these findings. And I'm going to my conclusions so we can have a discussion afterwards. In my opinion, there is a selected group of patients with heart failure who benefit from rhythm control, both in terms of symptoms and AFib burden, heart failure severity, and maybe even mortality. The question is how to best identify them. And I don't think we have the right tools present to identify this group of patients. So what I do in practice, and what many of us do in practice, we load the patients with amio, we do a trial DC, we cardiovert the patients, and then we try to assess, whilst they're already on optimal medical therapy, we try to assess if their symptoms improve, if their LV improves, and if they're able to maintain normal sinus rhythm. If this is the case, then yeah, we can consider PVI because maybe it can get us rid of the amiodarone, maybe not. There is one selected group where always normal sinus rhythm restoration should be pursued. These are the patients with tachycardiomyopathy. But if you think about the tachycardiomyopathy, you never know that it's tachycardiomyopathy before restoring normal sinus rhythm and seeing the dramatic improvement in the LV ejection fraction. So again, you have to give it a try and then to see if it works. Do not forget the 4S scheme and look here at substrate severity, atrial cardiomyopathy, atrial enlargement, dysfunction, and fibrosis. And here you have to be very careful because left atrial diameter does not always correlate with left atrial volume. And keep in mind that there are patients with small atria where you have a lot of scarring and a lot of fibrosis in the atria, and you can see these on CMR or on electrical maps, but you cannot see this on echo unless you do left atrial strain or some advanced technique. So it's not always about size or diameter or volume, and patients with large atria who do not have so much fibrosis or scarring. So we'll have more and more of these patients, elderly women, not the ones that I showed you in the trials, younger male with lower Charts-Fast scores, and we need to find the best modality how to treat them. When I was starting cardiology, age above 65 was considered a contraindication for ablation of atrial fibrillation. Then we moved to 70, then we moved to 75, maybe we'll move to 80, maybe we'll have newer methods. Thank you for your attention.